All right, so we're going to talk about some immunization updates. All right, so an overview. We'll talk about the National Vaccine Injury Compensation Act, reporting to VAERS, the National Immunization Survey results, the CDC Kindergarten Immunization Report, and then VFC and ISDH updates. Okay, so the National Vaccine Injury Compensation Act. How many of you know about this? A few of you? How many of you get questions about injuries or harm or bad side effects? Do you get a lot of parents that are concerned about that? Okay, so this is something we want to make sure that you guys are aware of. So it was created in the late 80s after some lawsuits against the vaccine manufacturers. And it provides compensations to patients who are determined by the court to have a rare, serious adverse effect. The big thing, though, is that it's a no-fault designation. So nobody is saying, yes, this manufacturer is at fault. It's just you can apply for funds through this program. So what does it mean for you? How many of you are religious about giving out VIS statements? That was a trick question. That should be everybody. Okay, so you're required to report then adverse events to VAERS. Do you have a VAERS coordinator, or do you know who our VAERS coordinator is? So let's introduce her. Let's see. Is Kim Cameron? She may have stepped out of the room. So Kim Cameron, who is our assessment epi, is our VAERS coordinator. And what happens is this protects you from liability through that no-fault designation. So VAERS stands for the Vaccine Adverse Event Reporting System. Healthcare providers have to report anything that is outside of the norm to VAERS. You use it to track vaccine safety. So we get a lot of questions about HPV specifically. How safe is the HPV vaccine? And if you go back and you look, so all the adverse effects have been recorded with VAERS. There have been very few documented serious side effects. And so that's why we try to encourage everyone to report everything. HPV is one of the most studied and appears to be one of the most safe vaccines that's out there. So the National Immunization Survey. So this is a telephone survey that was used to assess immunization status of parents ages 19 to 35 months. So the coverage has remained high and stable in the most recent one, 2017. We're over 90% for at least 3 polio, 1 MMR, 1 varicella, and 3 Hep B. 2 Hep A, the Hep B birth dose, rotavirus, and then the 431, 3314 series are actually the lowest ones. Now think about the telephone survey. How many of you have landlines? How many of you only have cell phones? Okay, so that has been identified as a problem with this survey. We're trying to move away from using this survey and actually using registry data on the national level to pull this data. So as you would expect, we have lower coverage among uninsured and Medicaid populations and in non-metropolitan areas. And the rates of children receiving no vaccines were nearly double in non-metropolitan areas. So some of the key takeaways were to increase awareness and then to use the VFC program. We are seeing some programs that are using private vaccine and then billing Medicaid. It's a better model to be able to only use the VFC vaccine. Minimize missed opportunities to vaccinated appointments. So making sure that you're assessing all of the vaccines that are needed, not just ones that might be required for school or based on that timing of the appointment. Minimize interruptions in health insurance coverage. How many of you have seen Medicaid patients that they're covered through Medicaid at one point, and then the next appointment they're not, and then they're back? So it's following that and making sure that we have continuous care with health insurance coverage. So the kindergarten immunization report, we finally are above 90% from MMR. Does that surprise you guys? No, do you get a lot? I always think MMR is one of those that people usually don't question. So what do you think? So do you guys see a lot of people refusing MMR? Yeah? I see a couple hands. So when I saw that for the kindergarten report, 90.4% was our new average. We had been high 80s the last 3 years. I was kind of surprised. To me, that's a no-brainer. We should be closer to that national average. Tdap and then Varicella, our rates have been very consistent, although we're still below the national average. So we always get the question of, what about the non-vaccine movement? Are we seeing a lot of people that don't want to accept vaccines? And really, our medical exemptions and religious objections have stayed pretty much the same. We are around about 1%, maybe just a little over 1%. The national average is 2.2, so we're not seeing a lot of that. CDC, through the Advisory Committee of Immunization Practices, their last meeting in October talked about it's not really the anti-vaccine movement or objections, it's access to care is what's keeping the rates low. I think when we look at Indiana, we don't have an access to care issue. I think we're having maybe not good follow-up on the parents to get those kids back in and complete those series. So one of the things that we deal with when we look at the kindergarten report is that school nurses, we run this report off a database that school nurses use. And so school nurses have to go and look in the registry for vaccines, and then they enter it into their school information system and then try to put it into the registry if we don't have record of that. So in some instances, school nurses were entering data 3 different times. And so to try to make that easier, we've developed an interface between the school information systems and the registry. Right now, we have 71 school corporations using this. We've sent about 454,000 immunization records. It's reduced manual data entry for schools, and it's improved the accuracy of the information that's going into the registry and to the school information systems. One of the reasons I bring this to you is that we want to make sure all the information on vaccines that you're administering are in the registry so that it does flow back and forth between the school information system and then the state registry. This is just a graph showing since July 1st, all the school immunization records that have been transmitted through this interface using this electronic interface. So the VFC and adult program updates. I'm going to talk briefly about provider recertification. It's holiday shipping time again, so we want to make sure we talk about that. HPV maintenance of certification, talk about some seasonal flu, and then also hepatitis A. How many of you live in counties that have had a problem with hepatitis A? Okay, if it's not come to you yet, it might be coming your way, so we want to talk about that and make sure that everybody's on the same page. Okay, provider recertification. So every year in December, we do a recertification. It is a federal requirement that all VFC providers become recertified through the VFC program. This is not something that's Indiana specific. This is something that every VFC provider in every state does at the end of the year. New for 2019, you're going to have to submit a photo of your storage unit. You have to have a standalone storage unit. So we've been talking about that for the last 3 years. A combination unit, so one that has a refrigerator on the bottom, freezer on the top, or vice versa, is not going to be allowed unless they both have separate motors and compressors. So if you still have a combination unit that you're using, you will not be eligible to be re-enrolled in the VFC program starting January 1st. Is that a surprise to anyone? No? Okay, good. We also need a signatory and the email. We need the email address of the signatory for your recertification or your chief medical officer. So a lot of times we'll send information out, and it should be going to the VFC coordinator. I believe it does go to the VFC coordinator and maybe one backup. But then we get something from the medical director saying, I never heard anything about this. Why didn't you tell me about this? And so what we're trying to do is to make sure we close that communication loop. We feel like if we're communicating with the VFC coordinator, that should be good enough, but we've heard from a lot of the medical directors that they want to make sure that they're notified as well. And then maybe one of the biggest ones is that when you're shipping or having vaccine shipped to you, you have to have 4 consecutive hours during the day for shipping. So we've had a lot of return vaccine recently where the vaccine was attempted to be delivered and we thought we had 4 consecutive hours, but we actually didn't. So if you are open, say from 9 to 12, and then you take a break for lunch from 12 to 1, and then you're open from 1 to 4, that does not meet the criteria unless someone is there over the lunch hour. It has to be 4 continuous hours. So if that is a problem, please contact your field representative or your health educator, and let's talk about that. So some important dates to remember with the provider recertification. The last day to order a vaccine is going to be at noon, December 6th. So you cannot order anything after that. The provider recertification will open December 7th, and then it will close December 31st. So we get this question every year. What happens if I don't recertify? At the end, at 12 midnight on December 31st, if you have not re-enrolled and submitted all your paperwork, you will no longer be a VFC provider in the program. Now, I'm not going to tell you we don't have a little wiggle room. We don't try to work with you. But legally, you do not have a contract anymore after December 31st at 12 midnight. So it has to be put in. There is a sheet that you will have to sign. It'll have to have a hard copy or hard signature, and then you fax it to us. So if you fax something in, please make sure you include your VFC PIN number on there. Does everyone know their VFC PIN number? That was another trick question. You guys all tired? Is it the end of the day? Yeah? Okay. Because we're going to talk till 6 o'clock unless you laugh at some of my jokes. That's all. Okay. Holiday shipping. Okay. So November 9th, there was no shipping. November 21st through 23rd, there's no shipping. December 14th through 31st, there's no shipping. And January 1st and 2nd, there's no shipping. So just remember, your order needs to be placed by December 6th at 12 noon. Now, does everybody remember what happened around New Year's last year? So all of our vaccine comes from Memphis. So all vaccine that comes to you guys comes from Memphis. And does Memphis get a lot of ice or snow? Not usually, but last year they did. And so they were closed, I believe, for 5 days last year. And so we had a couple of providers that hadn't ordered anything since November, didn't order anything in December, shipping closed, the ordering system closed, shipping closed, then we had this ice storm, and they ran out of vaccine. So I would encourage you, even though we always say we want you to keep 4 to 6 weeks of vaccine, look closely at that 6-week mark. What do you need to cover 6 weeks in case there's another delay? Now, we don't want you to order 3 months worth of vaccine, but if you need to order some extra vaccine to make sure you can get through the holidays, please do that. Please be mindful of storage. Don't order more than what you can properly store, but make sure that you do have enough vaccines to get through this time period. Any questions on that? What if it hasn't been 30 days? Please go ahead and submit an order for December. Jill? Yeah, so it's not 30 days, it's 1 per month. And so let's talk about that. We get that question quite a bit. Our job is to make sure that you have vaccine. Your job is to make sure that you're ordering enough vaccine to get it in. We never can control how many people you're going to see. We could have an outbreak, there could be something. If you get close on vaccine, please give us a call. Let us know. Even if it's, you've already had one order that month, we don't want you to have missed opportunities. So, if it's an occasional time that you have to call and say, hey, I need more vaccine, please let us know. We'll work with you on that. But by and large, it should only be 1 order a month. Any other questions? Okay. That's right. Okay, what does it mean when you go into the system and you look and your order says no accountability measures met, requirements met? Yeah, Jill. So did everybody hear that? Okay, so what that means is, I got it, Jill. What that means is there's a field that's been populated by an upgrade with our registry system. So when you see no accountability requirement met on there, that is an error. If there is a problem with your order, it'll be in the comments section. It'll say wastage not correct or TDAP missing or something. There'll be something in the comment field. So that is just a standard item that is in there. Yes?
When I place an order, it's not in that comment field. How long does it take for it to get
Okay, so the question was, when you place an order, it's not in that comment field, how long does that take? Most orders are processed within 2 days, and those comment fields should be in there with, comment should be in that field within 2 days after you place the order. Okay? All right, I'm going to move on. HPV maintenance of certification. So this was something that we did this year to try to improve HPV completion rates. So we looked at how many providers were below the 25% mark of completing their patients at 11 and 12 years of age. That is the benchmark. That's the HEDIS measure. That's what we're wanting to look at, is getting those kids vaccinated at 11 and 12. We had about 40% of our providers were under that. So currently we have 449 providers currently enrolled. What we're looking for is just having you do a quality improvement measure. So looking at your data, making sure that you're looking at who's eligible for vaccine, who's being vaccinated, and then making sure that you're tracking that. We recognize you're still going to have parents that refuse, so there's still going to be tough conversations. But there's also some educational videos that go along with that have been posted on the MOC website that'll talk about strong provider recommendation or how to provide that vaccine or recommend that vaccine. Those are the tips we're trying to instill, and hopefully we'll see some increased rates. When last year we were last in the nation for uptake in HPV for males, we've got to do something to move that mark. Flu season. So far, about 60% of all of our vaccine that's available to us has been distributed. 155, 590 VFC doses have been ordered. So that means that they've been sent out to providers. Now, we don't know how much has been administered yet, but that's how much is in the hands of our providers. We hope that people will still continue to make a strong recommendation. When do we stop seeing flu kind of being a hot topic? Anybody know? Usually around Christmas time. I mean, that's what we see. So orders start to slow around Christmas time. But really, when you look at the epi curve for flu in Indiana, we are seeing that January and February are our heaviest months for flu. So we can continue to vaccinate all the way up to March or April. So please continue to make that recommendation. So hepatitis A. So hepatitis A was one of those things that kind of snuck up on us. We had neighboring states that had high hepatitis A cases. Kentucky had, I think they're about 1,400 cases. Michigan is about 800 cases. Michigan's had 28 deaths. I think Kentucky's had 14 deaths. Right now we've had 2. So we're looking at making sure that we're going out and we're vaccinating all the high-risk populations that we can. Now, a lot of local health departments are doing a great job in dealing with their high-risk populations and then also their jails. But what we did is we took a strike team approach, hired 2 nurses and a clerical person, and then, actually it was 3 nurses. One person is operating kind of as the manager. And we're going out and we're working with counties to vaccinate at jails, homeless shelters, food pantries. So far, we've been to 26 counties. And then within those counties, we've been to 19 county jails. We've been at around 20 different community areas. So whether it's community center, homeless shelter, soup kitchen, food pantry. And then also, if you have an SSP program or a needle exchange program, we try to vaccinate there. So our high-risk populations for Hep A are going to be individuals that are IV drug users, men that have sex with men, individuals that have been incarcerated, and individuals that are homeless. The Advisory Committee on Immunization Practices recently just changed the recommendation, and for individuals that are homeless, they are considered to be now a high-risk category. We also developed a website where you can go, and then we have this dashboard that is updated every Friday. You can see that we've administered in the state of Indiana 85,000 doses of Hep A. Typically, we only administer, these are adult doses. Typically, we only administer about 6,000 doses a year. So we've done a great job of being out there and vaccinating. It also gives you a case count by county. So if you want to look at your county and see how many cases are in your county, you can do that. School requirements. So every October, early November, we start talking about school requirements for the next year. We will have them posted by December 1st. I believe the legislation says that we have to have them posted by November 30th. We're working to make sure that we're updating the information that needs to go out to schools so we can get that out in the early spring. And then we're also looking at what's going to be required for other activities. So an example would be colleges and universities. So IU, Purdue, IUPUI, ISU, Ball State, and I believe Marion University are all requiring incoming freshmen or incoming students, period, to have the 2-dose MenB series. So we're looking at that. I don't think we're at the point now where we can make it a school requirement, but that might be a piece that we look at in the future. Right now, I think with school requirements, the only thing we're going to be looking at is just rolling up Hep A. So that'll just, kind of like we've had in years past, although now we have it for 6th grade and 12th grade. So at the end of this next year, it'll be K through 7th grade. We'll have all of Hep A and then 12th grade. One of the reasons that we're looking at MenB and thinking about it as a school requirement is so that we can help cover it through the VFC program. If it's only being used as a college entrance vaccination, then that's probably going to be private pay or private insurance. So that's one of the things that we're looking at. Again, I don't think we're there yet, probably a couple years away, but that is something that we keep reevaluating. Just to give you an idea, we get a lot of questions about MenB. All of the college outbreaks in the last 3 years have been serogroup MenB. Recently, there was an outbreak at Syracuse, University of Southern California. There was one more, San Diego. So we're looking at that. We've not had anything here in the state of Indiana yet at a college campus, but I think we're just a case away. Michigan, a lot of our surrounding states have had cases. So what is the 4-day grace period? How many of you struggle with this? Nobody? Everybody has it perfect? Well, we can just go to the next slide. Now, so it does get confusing. And I tell you what, when we go to back to school time, we get a lot of calls on this. The 4-day grace period is something that CDC has allowed us to use. So if you have a minimum interval and you give it 4 days early, we can count that as valid. 4 days does not mean 6 days or 8 days. It means 4 days. So we get a lot of calls where a provider has given, I'll give you a great example. A provider has given hepatitis B 8 weeks, the 3rd dose, 8 weeks from the 2nd dose, but the child is not 24 weeks of age. So it's an invalid dose. And the doc will write a note saying, I believe that this dose is valid. It was within so many days, so I think we can count it. If it is not within that 4-day grace period, we cannot count it. It is an invalid dose and it'll have to be reported. So this 4-day grace period is just something that we have to where we have a little bit of leeway, but there's not a lot of wiggle room on it. The 4-day grace period does not apply to minimum 28-day intervals between 2 different live virus vaccines. So any questions or concerns about this? Because we seem to get a lot of that. Providers have to be very careful to make sure that we're within that minimum interval. We have to at least have that minimum interval met. 4 days would be something that we can look at, but if it's more than 4 days, we're not going to be able to address that or count it as valid. Okay, some common vaccine schedule errors. Polio, the booster dose is given before the 4th birthday. Hepatitis A, the 2nd dose is given sooner than 6 months after the 1st. MMR and varicella administered before the 1st birthday. That's something we see quite a bit at school time. Someone comes in to get 12-month shots, they're like a week early, so they go ahead and they get MMR and varicella. Not school, we see it when back to school, but they come in to get shots. It's administered before their 1st birthday. The registry will not count that as valid. And then the example of hepatitis B, and then live virus vaccines, given sooner than 28 days apart. We found that a lot after H1N1 in 2009, that once those children actually enrolled in school, they had a lot of invalid vaccines because they had been to the doctor, they had received a live virus, and then they went somewhere else and received the H1N1 vaccine, and those inactivated them, both of those. They both became invalid. So I want to talk a little bit about something that we did was a little different. We hear a lot of times that people don't want to take the HPV vaccine, that they're concerned about it. There's a lot of stigma around it. And I would agree with that. I think we started marketing this in the wrong way. We started marketing as an STI issue instead of cancer prevention. But one of the things we looked at was, when do individuals start making their own medical decisions? And so we went to the IUPUI campus and worked with them on trying to get incoming freshmen to be vaccinated against HPV. It actually morphed, and we started looking at HPV and flu, and then we added MenB. But just as an example, we did a preparedness exercise at IUPUI in October. In a 10-hour period, we administered over 1,600 vaccines to over 900 students. There were 500 doses of MenB, almost 400 doses of HPV, and almost 800 doses of influenza. What was very interesting is that my staff and I had a chance to be on the front line of talking with patients about this. And with HPV, a lot of it was how you framed it. And I know a lot of you already do this and do a great job at it, but I think it was real telling for us to be able to see this, that it was making that strong recommendation, making sure that they understand that they can take control of their health care and they can make this decision. So now we'll open it up for questions. I think there are some mics here if somebody has questions.
I actually have a question.
Yeah.
With the hepatitis A that you were mentioning, having the 6-month window with the 4-day grace period, we've gotten a lot of feedback from school nurses saying that that 2nd dose, if it was given a day or 2 early, that it's not accurate. You have to revaccinate. Is that true? Because it'll flag it and chirp that it's not.
So if it was given 1 or 2 days early from the 6-month minimum interval, the 4-day grace period, that will count.
Why does it flag it and chirp that it's not? It doesn't count.
It should, VJ, it should count. 4-day grace period is built in. Yeah, the 4-day grace period is built in the registry on all of those. Yeah, unless you have that 28-day window of a live vaccine, but Hep A would not be that, so.
Okay. I'm just curious if anybody else has that issue, because we get school nursing calling all the time and saying it was given too early, it needs to be given again, which our providers believe that there was a 4-day grace period, but when it became a required vaccine, CHIRP started flagging it, that it's not in the 4-day grace period.
Okay, do you have any examples of that?
I'm just saying, like, if it was given in February, that say, February 1st, and if it was given before the 1st of August, that 6 month, if it was given in, July 31st, it was given too early.
Okay, so we've had some problems with school nurses looking at their school information system, and the forecasting there did not have the 4-day grace period built in.
Okay.
That's why I was kind of asking for an example to see. And the other thing is, when you see those things or you get a report of that, please let us know.
Okay.
Something could have changed in the registry that we're not aware of. We get updates every month or so. We do go through and do testing, but just make sure you give us a call on something like that. But the 4-day grace period does still apply.
Okay, thank you.
Sure. Yes.
On our report of our vaccines that are not decrementing, we are noticing an increased amount that have been entered by other entities, such as a school nurse or a pharmacy, that are showing up on our non-decremented report as if we administered them. Is that a known issue?
Well, there's no way that a school nurse or a pharmacy they would have to enter those as historical. They wouldn't be able to enter something that would decrement unless...
Right, but they're showing up on my report, like if it says that my inventory is off and I'm going to look at my non-decremented, they're showing up on there. Is anybody else noticing that? So we can just ignore it?
As historical ones, yeah, you would ignore, those aren't the ones that aren't decrementing, are the historical ones. Yeah, are you running a patient detail report?
Yes.
Yeah, so you run it by service?
Yep. Same thing I've always done, not changed any of my processes. I've noticed an increased amount in the last several months, but it had happened infrequently prior to that. To my coordinator, to who my touch point person is.
Yeah. So let's make sure everybody hears that. So if there is an issue, whether it's doses not decrementing, whatever the case is, if you're having a problem with stuff in the registry, make sure you call the CHIRP help desk and talk, because it could be something that others are seeing and we don't know about it, or it could be just an isolated thing, but that's what the CHIRP help desk is there for. So I want to make sure that everybody heard that response. Okay?
Yeah, Dave, I have a couple of questions. Regarding the outreach that you did at the college campuses where the kids were responsible for their own choices and that kind of business, my question is, did you guys get any kind of backlash from parents finding out that this happened and them calling and just reading you the new one because you gave vaccines to them?
I have not received a single call like that at this point. But let me tell you what I did see, which was kind of interesting. We saw a lot of parents say, well, let me call mom and see if I should get this vaccine. And so we did a little kind of an education piece that, you're over 18, we have this here today, you can make this decision. Some people said, yeah, I'll go ahead and do it. Some say, no, I want to talk to my mom about it. But mandatory reporting has only been in place since 2015. So we did have a couple instances where we asked if someone had had the HPV vaccine, and they said, no, I don't have it. And so they went ahead and got a dose. And so we looked in the registry. There was nothing in the registry, so we administered a dose, and only to find out that they had completed the series. And so they were mad. They were like, well, I trusted your medical advice to get this vaccine, and I'd already had it. Well, you didn't know you had it, and it wasn't in the registry. We didn't have any way of knowing that. So those were the only kind of calls we received based on that.
I just had vaccinated an 18-year-old that came in for her senior shot and talked to her about all of the recommended vaccines that she should get, and she got them all, and the parent called me half an hour later and just lost her mind. So, I was just curious if there was any problem at that point.
Of course, if they're 18, they can make their own decision.
Well, and
Mom
that's
can
what
still
I
be
told
mad,
her. And in my brain, I didn't say this out loud. I kept these voices in my head. But I'm thinking, if you're so concerned about what your child's going to get, then don't send her alone to the doctor's appointment, or accompany her. She came. She said this is what she wanted. She's a legal adult. I did it, but I was kind and held my tongue.
I'm glad that was only in your head. I'm glad you didn't say it out loud.
I kept the voices in my head. I really did. Okay. Then my next question was the 317 Hep A doses.
Yes.
I just had an additional 50 doses brought to my clinic. Are we still supposed to be hanging on to those for emergent type, we need to get these people vaccinated because of their exposures, or can we, again, give it to folks who qualify for 317 vaccine that just come in and say, hey, you know what, I'm scared about getting this, I want to get it?
So if you are an adult provider and you were given hepatitis A vaccine, we are first looking at those high-risk populations. So incarcerated, homeless, IV drug users, and men who have sex with men. We're also opening it up to someone that doesn't have health insurance or is underinsured for the vaccine.
So we can go ahead and give it to somebody who doesn't necessarily fit the high-risk
Correct.
profile.
Correct.
But still qualifies.
However,
for
just the first dose. So right now, all we're doing in response to this outbreak is doing dose 1. And we recognize there's another. I said if you're an adult provider, though. Okay, so if you're a local health department adult provider, sorry. But dose 1 is all we're doing. So we have talked with the medical scientists for both companies, and with 1 dose of hepatitis A vaccine, you are somewhere between 94 and 96% protected for up to 10 years. So we're not going to worry about that second dose until we get through this. We're going to only focus on the first dose.
Okay. My last question is a question specific to the HPV MOC. And I
Okay.
don't know if you would definitely know the answer to this or what the story is, but I've been doing it for a couple of months, and I'm looking at my data, and the only thing that it asks as far as follow-up appointments is a 6-month follow-up appointment. Well, not all doses I give are going to require another appointment because I'm completing the series. Some people need a 2-month appointment, some people need a 4-month appointment. Am I supposed to be documenting all follow-up appointments under the 6-month? Because if I don't do that, it's going to make it look like my follow-up appointment rate is going to be terrible. So are you only really interested in the kids that are 11 and 12 or under 15 that we're starting? Because I'm documenting every dose I give.
Yeah, we want you to document every dose. Cheryl, let me get back to you on that. I don't know
Okay.
that. I don't know about the variables on different
Okay.
doses and the spacing and how that should be recorded.
Okay.
Good question, though.
My question is, with the 4-day grace period, does that have any effect on expired vaccines?
Does the 4-day grace period have any
For instance,
impact on expired vaccines? So you had a vaccine
it
that was
expired November 4th, and it was given on this, November 4th, and it was given on the 6th.
it's definitely not valid. No.
Okay.
No.
This is more an IT question. When you go to order your vaccines, is there any way they can put a button at the bottom of your list of vaccines where you can click it and it would populate zeros all the way down, and then you go and change the zero to the ones that you do want? It would be less errors on our part, and it would be a lot easier.
So that is a platform that we share with 13 other states. So we're not able to change that at this time, but we can put that forward as a possible change. Indiana is part of a consortium with these other states, and we all put in our ideas and vote on them and try to make these changes. I can't guarantee that that'll be something that we could get changed, but we can definitely, I'm pointing at VJ, like, remember this and write it down. So we'll definitely look at that. Sounds like the whole crowd wants that? Okay. So we'll at least suggest it and see what we can do. Any other questions?
So we've had a couple of patients that we've gone onto their CHIRP website and looked at their vaccinations, and they have weird vaccines from places they've never been before.
So it's been merged with another record, maybe?
I don't know. Like one kid was documented that it was given in Lincoln, Michigan, and mom said he's never been to Michigan, let alone gotten vaccines. And then another patient had like 18 DTAPs and just like weird numbers. And so moms don't keep track of the cards. And so it's just a mess for us to try and figure out. I didn't know if there's something that we are doing on our end or if there's something we need to do to fix that.
You know, anytime you see something like that, please call us at the CHIRP help desk
Okay.
and see, because what we'll need to do is go back and look. So CHIRP always keeps track of how vaccines were reported to us, so it could have been a merge with another record or there could have been a problem. Anecdotally, I can't tell you just
Right.
standing up here, but yeah, if you'll give us an example or call us when you have those problems, we'll look into
Okay.
them. It's really easy to unmerge a record and to clean up a record. We just need to know about it. Yeah, most likely it was probably a merge, but yeah, we just have to work through that. Okay, if nothing else, thank you. I believe, oh, okay.
Sorry about that.
No, you're fine.
Last year when we were here, we were talking about underinsured.
Okay.
Are there any more underinsured people? Or
There
is
are
that-
still underinsured children,
Okay,
right?
And
But
what-
remember, you have to verify that they're underinsured.
Yeah.
So you have to call their insurance and make sure that that vaccine is not covered.
okay. I thought we were told that there was a grandfather in for until, a certain time when insurances could be underinsured, and then after that, they should have all caught up.
Right, so under the Affordable Care Act, all vaccines should be first dollar, full dollar, unless your policy had not been changed since a certain point. And what we're finding is that's still happening in some cases. The problem with the Affordable Care Act, I think, I'm not an expert on this, is that there hasn't been a lot of follow-through on that. And so we're still seeing that. So if you have, a certain provider that's not covering a vaccine, Dr. Box, who was here earlier today, had been talking about before, if we can find certain payers that aren't covering vaccines, we'll address that with them on an individual case and try to get that changed. But we are still seeing underinsured kids, so we need to make sure that we're still checking on that.
Okay. My other question was about CHIP kids. We are in FQHC, and somewhere during the year, there was something sent out about not vaccinating with VFC vaccines through an FQHC CHIP kids. Is that?
Okay,
What about
so do you want the legal answer or do you want the answer that we're doing?
What we're doing?
Time?
I know
Okay.
what we've been doing, but
So actually, at this point, we can't differentiate between CHIP kids and normal Medicaid kids. They have the same card, so we don't know what it is. So we are still vaccinating CHIP kids with VFC vaccine. We're working on trying to correct that. That is actually against the federal guideline. But we have been talking with CDC, and they know that we do not have a way of figuring that out at this time. The best way for us to be able to address this is to go to Medicaid and have them pay for the vaccine on the back end so that we're recouping those costs. But right now, we don't have a choice, so just use VFC vaccine.
okay, thank you.
Yep, last question, and then we're going to have to go.
Okay, so we have a lot of issues with twins decrementing over. We'll get in there, one twin will be in the CHIRP system, one twin won't. Should we be going ahead and creating the second twin or calling to see if at one point those have been merged?
Yeah, please go ahead and call. A lot of times what happens is you don't have birth order in there, so one of one, or one of two, or two of two, and then that causes those to be merged. But if you'll call the help desk, we can see if we can get those unmerged.
Okay, thank you.
All right? All right, I'm going to pass it off to Jill.
Okay, so we have a few minutes. We want to hand out some door prizes for participating today. And so we got to get it quick because they're going to start sending people in here in just a couple minutes. How many of you put a card in for the vaccine cost at the immunization table? So I have that total of what that vaccine was. I think we went anywhere from like 1,000, like 1,500 up to 750,000 were the guesses. And our closest guest, and I'm not sure if she's even a VFC provider, nobody put their VFC pin on it who were closest. Do we have a Monica Bird? No? Okay, I'm sorry? And so the next one would be Joni Miller. I'm pretty sure that's a VFC provider. All righty. So the total in that cookie jar, that container, come on up. She's gonna hand you a gift card. Joni guessed $18,000, and the total amount in there was $18,294. And that's a minimal amount, actually, a very small amount on vaccine loss. It is not uncommon. This one contained a lot of Menactra and other things, but I didn't include any PCV13. This is what's been sent into our office that was never actually returned properly to McKesson, so it became part of my project. So next, real quick, we're going to play a little game, and I'm going to ask you guys to come up here, again with vaccine prices. I'm going to choose. And we have somebody from the Riley Physicians Clarice office. Okay, and then and then I need someone from the High Point Health Primary Care, M15S01. Anybody here still? Yeah, we can, and you can. So I just am going to take a poll on what, we'll go ahead and just go with you there. What do you think is the cost per dose of Recombivac's Hep B vaccine? Per dose or box? Dose. Okay, so one dose of hepatitis B vaccine at the CDC cost is actually $12.30, but we're going to give you a gift card for participating. How about somebody from M64S03, Dr. McMurtry's office? Is anybody out there? I'm just going off of your sign-in sheets. No? How about Riley Physicians at Meridian Crossing, M29, M14, L14? Yep, just go around. You just choose. Okay. Can you guys give us the price of PEDVAX Hib per dose? That is $13.09 per dose. All right, let's pick another one. Okay, the price per dose of ProQuad, MMRV. $135. She is pretty close. It's $125.11. Congratulations. Next table. We're going to go with a dose of Minvio. So that is really close to the private dose, but Minvio on the CDC contract is $73.83 per dose. But good job. We just kind of want to give you guys an idea of what you're using out there. So let's do another one. I'm going to go with Gardasil 9. She's going to come to a table. Gardasil 9. That one is $168.10 a dose. So a box of HPV 9 is over $1,600 in your refrigerator. Please do not waste this one. It hurts badly when that one comes through. Okay, we got another one. How about Rototec? A single dose of Rototec. Rototec per dose is $70.49. Congratulations, though. We'll do some. Next one, a dose of Daptosil. $30. That is the exact price on the private pay list that I have, but it is $17.61 per CDC contract. How many more we got? We're going to go with a dose of Pentacel. Who we got here? Oh, are we? Oh. Pentacel. Pentacel is $58.33 a dose, so very close. Do you have one, Diana? Let's do a dose of Havrix. Pediatric. It is $19.58. Let's go with Hebarix. Actually, Hib is one of the cheapest vaccines, and by all means, it is very important, so I don't mean to make that sound weird, but that is $9.65 a dose. Are we doing more? Okay, Diana. How about a dose of IPOL? IPOL is $13.30 per dose. Now, granted, that comes in a 10-dose multi-dose vial, so multiply that by 10, you would have $133. We're running pretty close to time. We got several left, so MMR. Diana, do you have one for MMR? $70 for MMR. It is $21.05. So I think what this is, it's very surprising what vaccines are, what they cost, what it is in your refrigerator. It's kind of looking at what orders would be. We got another one here, Bexero. It's $103.40 at the CDC price. Diana, you got somebody? Let's do Pneumovax. This is not readily recommended, but it is something that we vaccinate with. It's $53.11 per CDC dose. All right, Tenavac. Okay, you go right here. Sarah, Tenavac. It's $20.05. I'm running out of vaccines. Varicella. $98.24. Sarah, let's do a dose of Boostrix. $31.37. Diana, dose of Infanrix. $18.19. Who we got here? Sarah, Kenrix. It's $40.19. That combined DTAP and IPV. Where are we at here? Oh, go ahead. Let's do Pediarix, Allie. $57.97. All righty, is that, we just have one more each? Vacta, Sarah, Vacta. It is $19.29. An Adacel. Diana, you have one still? Adacel. It's $30.89. Is that all of them? Okay. We wanted to find a random way to get you guys some gift cards for coming, so that's our best way of doing that. We had hoped to do a little bit more Price is Right kind of game, wheeling and dealing up here, but we just want to make sure everybody enjoys those gift cards. Sarah, do you have any parting words for us, or?
Well,
Well, thank you all very much for coming. You're welcome to stay in this room if you want. There's a closing plenary session, but otherwise you're free to leave. This is your last chance to sign in, come up and see me up at this table. I saw some of you frantically texting your coworkers, like, what's my VXC pin? So if you figured it out, please come see us so you get credit to attend. But otherwise, you're free to go, and thanks for coming.